Does your period disappear for months at a time? Do you have so much hair on your chin that you need to shave it? Do you struggle with acne despite being over 30? If you're a woman of childbearing age and you answered yes to any of these questions, you may have PCOS. All right, everyone, welcome back to Every Mama's Midwife. If you're new, my name is Jess. I am a certified nurse midwife, advanced registered nurse practitioner, and infertility mom. And I am currently on an IVF journey. So if you like learning about infertility, recurrent pregnancy loss, pregnancy after 35, or you just want to follow me on my journey, please like, subscribe, turn on the notification bell, and we post new videos every week. This week, we are going to be talking about PCOS, or Polycystic Ovarian Syndrome, and specifically how PCOS causes infertility and what you can do if you have PCOS and you want to become pregnant. According to the World Health Organization, PCOS affects between 8 to 13% of women worldwide, which is crazy high numbers. And I always second guess myself when I'm talking to a patient about PCOS and I want to be like, yeah, like 10% of women have it. And then my brain is always like, no, that's way too many. That can't possibly be right. So I did double check before this video, and those numbers are accurate. And I find most of the time when women come to me thinking they have PCOS, most of the time that they are right. To diagnose PCOS, we use what's called the Rotterdam criteria, and you have to have 2 out of 3 of the conditions on the Rotterdam criteria to be diagnosed with PCOS. And 2 of the things you don't even have to run tests for, and so, technically women really are able to self-diagnose. So number 1 on the Rotterdam criteria is oligomenorrhea, which just means infrequent periods and typically less than 6 per year. I do frequently find that when women come to me thinking that they have PCOS, they will get a period once every 2 to 3 months, or sometimes they'll have like super infrequent periods and will only have like 1 to 2 periods a year. Number 2 on the Rotterdam criteria are signs of hyperandrogenism or blood work indicating hyperandrogenism. And I find most of the time you don't actually need blood work to confirm hyperandrogenism. And this just means like excess of those like male hormones, so like testosterone, things like that. And typically that's going to be seen in persistent acne, hirsutism, which is just really dark body hair, like women who are blonde but then have like crazy dark black arm hair, or have like so much stubble on their chin they feel like they have to shave it all the time, and then they've got a 5 o'clock shadow and they just can't keep up with it. And then also difficulty losing weight. And unfortunately, difficulty losing weight is a thing for a lot of Americans. And so I find just that one thing is probably not enough to diagnose signs of hyperandrogenism. But the majority of the time, women coming to me thinking they have PCOS, have hirsutism, have really bad acne. And then if you don't, you could do blood work. Typically like a testosterone level over 70 would indicate hyperandrogenism as well. And then number 3 on the Rotterdam criteria are polycystic ovaries on ultrasound. So you would need an ultrasound to diagnose the third portion of the Rotterdam criteria. If you remember from last week's video where we talked about luteal phase defects, the menstrual cycle is broken up into 2 portions, the follicular phase and the luteal phase. And in the follicular phase, the ovaries have multiple eggs that they're trying to mature. One eventually becomes dominant and then releases, ovulates, and then that's when you enter the luteal phase. And typically 14 days after you enter the luteal phase, you'll get your menstrual cycle if you're not pregnant, or you'll get your period if you're not pregnant. With polycystic ovarian syndrome, there are an abnormally high number of follicles on each ovary, typically more than 12 on each ovary. And so because there's multiple follicles, none of them is ever becoming dominant. And so none are ovulating, and then there's no luteal phase to enter into or decrease in progesterone to then ever trigger a period. And so that's why women with PCOS are not menstruating as often and also having a really hard time getting pregnant, because typically they're just not ovulating very frequently. When I first became a midwife and when I was in school, 6 to 9 years ago, I was taught to check luteinizing hormone levels and follicle stimulating hormone levels and testosterone and DHEAS and all these other hormones in order to diagnose PCOS. And I'm really grateful we've moved towards using the Rotterdam criteria instead, just because you would draw all of this blood work and then typically not even know what you're going to do with half of it. It typically was not going to change the plan of care. And so I find most of the time I can actually save my patients a really big lab bill and not order, hormone after hormone after hormone when diagnosing PCOS. But one thing that I think is interesting is typically women with PCOS will have higher levels of luteinizing hormone, and that is the hormone that you use or that you try to detect when you're using ovulation predictor kits. And so it's not uncommon for women with PCOS who are trying to get pregnant to come to me and say, like, I'm getting positive ovulation predictors all of the time. It's like I'm constantly ovulating according to these predictors. And because they have that persistently elevated level of luteinizing hormone, it's inaccurately giving them a positive ovulation predictor when really they're not ovulating at all. As a healthcare provider, I love helping women manage their PCOS just because there are so many options out there. There's multiple drugs available. There are, alternative therapies as well. And so I just have a lot of tools in my toolkit. So if I offer a woman something and she's like, oh, it doesn't sound like it's for me, then usually there's something else I can offer her. All right, everyone, sorry for the costume change. We had some sound quality issues with the second half of this video, so we decided to just re-record it. So anyways, moving on. Option number 1 in my toolkit for helping women manage their PCOS is a medication called Metformin. Metformin is a pill that's usually prescribed to patients with diabetes. It helps them manage their blood sugar, it helps your body utilize glucose better, and part of the increased androgens that come along with PCOS can be due to insulin resistance and increased insulin in the body. It used to be a first-line medication for PCOS for ovulation induction. A lot of times when you start someone on metformin, they will typically lose some weight. And then once their insulin resistance is, improved, then they'll start ovulating spontaneously and spontaneously having periods. But it's not currently recommended for ovulation induction. It is still a good medication for women with PCOS. It can definitely help with weight loss and it can trigger spontaneous menses. But if you're going to a healthcare provider specifically because you have PCOS and you want to be pregnant, they shouldn't just be offering you metformin. Unfortunately, metformin does have some pretty gnarly side effects. I would say probably at least 25% of the women that I start on metformin don't continue it after the first month just because of the GI side effects. Specifically, it can cause some really, really awful diarrhea. And I've had patients come to me and say, like, I was in the bathroom all the time. I can't live like that, which is understandable. I do find with the Metformin XR or the Metformin extended release formulation, there are usually less GI side effects. And I also find that if I can work patients up in a stepwise fashion, starting them on a really low dose and slowly increasing the dose over the span of about a month, then sometimes I can help them tolerate metformin, but it's certainly not for everyone. So option number 2 in the toolkit is Clomid or Letrozole, which really should be the standard of care for inducing ovulation for women with PCOS. Clomid and Letrozole are both usually taken cycle days 3 through 7. So once you get your period, on the 3rd day of your period, you would start taking either Clomid or Letrozole and just take it for 5 days. And it's going to increase the follicle stimulating hormone in your body and encourage your ovaries to make just, one egg and encourage that egg to mature and then ovulate and then give you an opportunity to get pregnant. They're certainly not foolproof medications. So I find a lot of times OBGYNs will prescribe Clomid or Letrozole for 3 rounds. And then if a patient is not pregnant, send her to reproductive endocrinology. If you don't get satisfactory results or don't get positive ovulation with just Clomid or Letrozole, fortunately, there are medications to help the Clomid and Letrozole work. Certainly we had to go down that route when we were doing IUI or intrauterine insemination. So I would take Clomid, or actually it was usually Letrozole, and then also add injections of follicle stimulating hormones several days later. And sometimes then also what's called a trigger shot, which is an injection of HCG or human chorionic gonadotropin, the pregnancy hormone, because if you have a follicle that's growing and growing but just not ovulating, that shot of HCG, but called the trigger shot, will then trigger you to ovulate. So don't panic if you've done Clomid with your OBGYN and you didn't get pregnant. There are still other options out there to help you ovulate. Clomid and Letrozole can also have some kind of rough side effects. A lot of women will experience mood swings on Clomid. I know I certainly felt more depressed when I was taking Clomid. And now I think the standard of care is more moving towards Letrozole instead of Clomid, just because Letrozole tends not to have as many emotional mood swings. And with Letrozole, there's less of a risk of twinning, whereas with Clomid, you're more likely to make an egg from each ovary, whereas with Letrozole, you're probably only going to make 1 egg. And then if medications aren't for you, option number 3 in the toolkit is good old diet and exercise. There is fortunately lots of good research on the best diets and the best exercise for PCOS. I actually had the opportunity to go to a
infertility conference about 18 months ago, and one of the speakers was specifically a PCOS wellness coach, a nutritionist, and she had tons of great research. There's ample research that shows a Mediterranean style diet is the best type of diet for women with PCOS. So that would be like decreased saturated fats in your diet, so minimal like dairy, red meat, increasing healthy fats like walnuts, salmon, avocado, and then watching those refined carbs, doing like lots of fresh veggies, stuff like that. And there's a really great book that I actually recommend to all women who are trying to get pregnant, but it's really specifically geared towards women with PCOS, called The Fertility Diet. And I don't have my hard copy with me because I actually loaned it to a friend with PCOS who is trying to get pregnant. But The Fertility Diet does a really good job explaining which fats are going to hinder ovulation and which fats are going to help ovulation. And one of the things that is great that they emphasize in that book is even just like a 6 to 8% weight loss can trigger spontaneous ovulation. So that's manageable for some women. And then along with that, the conference I went to talked about different types of exercise for PCOS, and specifically research has found that HIIT workouts, and that's high intensity interval training, are better for improving insulin resistance than like extended cardio workouts, so like running for an hour or something like that. So I thought that was interesting to know, and you can usually find HIIT workouts for free on YouTube, and usually they're about 20 to 30 minutes long, and they are really, intense, really crank up your heart rate. And then along with the diet and exercise, the PCOS wellness coach also talked about the best supplements for women with PCOS, and these are just things you can purchase over the counter. She did talk about how women with PCOS typically have lower vitamin D levels, which I did not know. And so that is something then I started testing all of my patients with PCOS for. And that's something I do test for a lot just because I'm practicing in the Pacific Northwest. It's dark and rainy here a lot of the time. So a lot of the women I see do have low vitamin D. The recommended dosage for women in the Pacific Northwest is 2,000 international units daily. And I usually recommend taking that on top of whatever's in their prenatal vitamin, because usually it's not a ton of vitamin D in a prenatal vitamin. And she also recommended inositol, which is a supplement that improves insulin sensitivity and decreases androgen levels. And specifically, you want a 40-to-1 ratio of myo-inositol to D-chiro-inositol. And that's something you can actually find readily available on Amazon. And usually it does come in that 40-to-1 ratio. And so if someone's having wonky periods and they want to take it, I always say, sure, that's, could help. It's not going to hurt anything. So there are a lot of options for managing PCOS. And occasionally women will come to me and tell me that they were told they could never get pregnant just because they have PCOS. And that is absolutely not true. So if anyone has told you that, please, please, please get a second opinion. Most of the time, there are lots of things we can do and that we can offer to patients to help encourage ovulation if they're not ovulating spontaneously. If you found this video helpful, please like, subscribe, turn on the notification bell. We post new videos every week. If there are other infertility topics you'd like to learn about, please leave them in the comments. Next time, we're going to talk about low sperm count. Super exciting. But yeah, thanks for joining. Thanks for watching. I'll see you guys next time.